Okay, I failed as a moderator. So what I'm going to do to my panelists is say, we're going to cut the period where they asked each other questions to turn this over to you all. Okay, so what I'm going to challenge you though to do and ask is, instead of focusing on a detail of any one particular model, to try to take this to the bigger concepts of what does this mean to you and what do you want to hear them reflect on related to our larger question of how as a community do we create this taxonomy and move towards models that are scalable. That's our long-term goal. So what did you hear today that you want to hear more about that didn't reflect what you already knew, or that you want to underscore for that group of people that Peter said will go into a dark room somewhere after this meeting and try to build the taxonomy that you want to make sure they think about? Okay, is that the question? And we invite people to come to the mics, and if there's a passable one. So. Please.
Is this on? Hi, Sherry Kaplan, UC Irvine. We've been hearing a lot about sort of the traditional approaches and systems redesigned and how they don't work for high needs patients, because they follow the 4 Fs: find them, fix them, follow them, and finance them. And I'm going to focus on the fix them part, because if we believe that, in fact, the healthcare right now is not organized around functional status clinics. You don't go to functional status clinic. You go to disease clinics, and you go for disease management. If the proportion of functional status that's mutable, even by excellent medical care, the way we provide it right now, is limited, and slides today show evidence of that, the number of chronic conditions doesn't match the proportion of functional impairments that actually cost so much, then are we still thinking inside the box, and are we dooming the healthcare system to think perennially inside the box from 6 feet under if we don't start thinking more expansively about how we persuade the public not to have medical care, for example, or do other things, or if we risk expanding and medicalizing functional status so that now we've caused dependency in the public on medical care. And David, you'll be sensitive to, when you start pulling things away from the public, how much screaming goes on about the USPSTF recommendations, for example, because we've persuaded the public that medical care can do what it can't. And that's maybe improve functional status. So I would like to hear a little bit more discussion about what the healthcare system would look like if we're actually trying to improve
I applaud you for muddying the waters. That's exactly what we needed. So which do you want to, okay.
Well, I'll just start. I mean, what I really liked in the other panelists' presentations is that one way or another, they work because they are inserting a discussion about function into the plan of care. And by doing that, they're moving the locus of control away purely from the medical system to a place where the individual and their family has more say. And I would just offer, we need to do that a lot more. But the ones that look successful are the ones that have really figured out how to do that. And I guess my second point, just because there's so many, I'd like everybody else to respond, my second point would simply be that there isn't a one-size-fits-all solution. So for the people here who are going to be sent off to the dark room, you know, I think this is not about one big demonstration project where everybody has to do the exact same thing for everybody the exact same way. It so totally won't work. And so the needs for various populations, whether you have chronic behavioral problems, a mixture of substance abuse and homelessness, longstanding functional limitations but not cognitively impaired but no function. I mean, those are very different populations and very different people, and the solution set for injecting a functional discussion into the medical system will be different.
I'm going to ask our panelists, each one will get one so we get more people up.
I'd like to raise 2 questions, and the more I hear people's comments, the more I think they're connecting perhaps across the whole conference. So one would be the following. The amount of care that's needed, the number of people who are aging, gets bigger and bigger. What I'd like to ask people to comment on is trying to get greater value in the caretaker system. And in specific terms, why can we not, or can we, shall I say, use relatives and families identified as primary caretakers, call them whatever you want to, that would address part of what you were talking about with regard to function. But if we incentivize them and provide them with some kind of reward for that, maybe we get a better motivated caretaker, and also the caretakers who are doing it are kind of appreciated. And the second thing I'll just toss in quickly is that if there's one thing that comes across here for me, it's the extraordinary flexibility, or sorry, variation between patients, patient populations. And so I think I like the idea. Go to the patients and let's ask what they want, but realize some may hold needs in common. Many will have individualized needs, and we ought to be thinking about how do we respond to that individualization. And one thought I had was, what if you, in a compensation or reimbursement model, allow some allocated monies to the individual patient to designate putting where they want?
I'll just jump in. There is a national demonstration and series of laws that are actually doing some of that, and if others want to talk about that, but the cash follows patient model in Medicaid is doing that. Does anybody want to? Yeah, the cash and counseling program. Does anybody want to? Okay, we'll let that one stand. Great thinking. Move them here.
I'm Leighton Huey. I'm a psychiatrist and associate dean at the University of Connecticut. And I was saying to Peter at the break that mental health conditions is a swamp. And so I think I'm heartened to hear all the attention to mental health conditions, but what are we really talking about? The assessment process in behavioral health for all disciplines is terribly burdened and complex and often inaccurate. So we talk about mental health conditions, but what are we really talking about? And I would say that the diagnostic system is a huge problem, despite the good intentions of many people who have been working for years on trying to make a difference, but the accuracy is just not there, and how we are training people in the trenches, residents, psychologists, social workers, and so forth, are all relying on this Bible as if it is God's word. And so all one has to do is to think an individual fits the criteria. That means they have the disorder. Well, that's nonsense. So what are we really talking about? In the GAO data that was in the briefing material and in the comments, many comments that people have made about the importance of mental health and the social determinants of health in constructing a system that's going to be functional.
I'm not going to answer that one. Helen Burstyn, National Quality Forum. Thank you for a really stimulating panel. Pretty clear from everything we heard. We're clearly paying based on the way we're currently performing and the way we're delivering care. And I heard Bruce's commentary about, stop thinking about it as a problem list. But frankly, from a measurement perspective, that's still how our measurement enterprise is built. It's built condition by condition. So I just would like your thoughts about if we want to move to truly doing the whole patient and holistic care, we need such a huge paradigm shift that simply saying we'll do functional status and then some of these other key indicators won't be enough. Do you have any thoughts about what it would take to truly move the system towards a very different paradigm of the whole patient, and also how that potentially fits into what's happening with alternative payment models and the opportunities potentially presented?
So I just can't resist, even though nobody else has had a chance. So I think two things are true. We make things in healthcare far more complicated than any other industry imaginable. And we are not the only high-cost, highly regulated, low-margin business out there. I'll just say that. I mean, you can crowdsource your way to answers. Whole industries move on a dime in ways that we are just unwilling to do because we're so busy searching for a p-value less than blah, 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 blah. So I'd answer this in two ways. I think we need, and again, going back, I really love these two presentations because each of them in their own very unique way. And when you look at the other successful models that are out there, they really do find the person and the patient in their own way. That's their secret sauce, and that's the basis of how they think about bringing services and caregivers, paid and unpaid, together in a more thoughtful way. So I think that there are ways that we could begin to measure quality better and to insert function into that. I turn the challenge around to places like NQF and other real thought leaders about quality. We need a new set of simple measures out there tomorrow, not 5 years from now, not 7 years from now. We need to incubate new measures, and they don't need to be complicated. I mean, I would just offer, if we ask 3 simple questions to folks: how confident are you that you understand your care plan? How confident are you that there is somebody you could call when you have a problem? And how confident are you that you would reach that person? I just guarantee you, if health plans were held accountable for those 3 questions, I don't know if they're valid and reliable. It's an opportunity, right? So I would challenge you guys and others like you to really sort of push the envelope.
And it's a great setup for our final session today, where I think we're going to try to answer a little bit more. So we will come back to that, Dr. Burston. Please.
I'm Dr. Amita Ristogi, working for a nonprofit HCI3, and this statement is my personal views. I've listened with great interest to all the models that were laid out today. And the one question that comes to my mind, I grew up in India. I practiced in United Kingdom for a while before I moved to United States. So I've seen how healthcare is practiced at least in 3 continents. And what comes to mind is patients, when they're sick, they don't want to go anywhere. So why can't the doctor go to them? In India, when I was a child and I was sick, the doctor came to my house, and that made me feel so much better. I was 90% cured just because he came there, and the 10% was the medicine he gave me. In England, general practitioners, they go home. They go home to the patient's house. They see the setting. They see what needs are needed. The GP then coordinates the care if any specialty care is needed. In America, now I've been living for about 25 years, I have 4 sets of parents, 2 in America and 2 in India, who I've been managing. All 4 are above the age of 80, 2 of them above the age of 85. None of them been hospitalized even once. I can tell you that. I can guarantee. I manage them, keep them out of the hospital. Sepsis, treated at home. Okay? All these problems happen to everyone. All sick patients, all older people get them. But we can do it. If I can do it for 4 parents, then why can't we have a system that can be a patient's advocate and take care of many of these people at home where their needs are in their social settings? Thank you.
Thank you for pushing us to think further.
Thank you very much. I just want to make a comment. I'm David Seberg from the University of Tennessee, and I'm representing the American College of Emergency Physicians. The emergency department, which I heard this morning, in the last 30 years of my career, is unnecessary, expensive, and generally not good places to be. But I'm not going to argue with that today. But I did want to make the point that really the emergency department, as we look for the high-need patients and getting them into a coordinated system of care, the emergency department can fill a huge role. It is a portal of entry. It is part of the medical neighborhood. And as we develop programs, we need to include the emergency department. We have 140 million visits each year. We have at least 140 million visitors with those patients coming in. That's a huge segment of the population. 70 to 80% of admissions now are coming through the emergency department. So emergency departments are looking now, even today, of putting systems around their emergency department of care managers, navigators, to help these patients navigate the medical system. We're using community paramedics to go out to the homes. As we look for solutions, I want to bring up that the emergency department, rather than being a negative metric, really can be a help in the solution of this.
Thank you. Why don't we go here and then we'll come back.
Lauren Harden, I'm a nurse and I direct a large complex care center for Trinity Health, and I'm here representing the American Academy of Nursing. One of the themes I've heard you talk about, in addition to needing to see the holistic view of the patient and have person-centered care, is the interprofessional team and the success of the multidisciplines coming together in a shared plan of care. What I see in my work is it can be very challenging to transform the culture. So I think it'd be interesting to identify the core themes that make that happen by looking at successful models. What are the ways that we can learn it's not about a discipline or a person? The most effective person in a case might be the community health worker, or it might be the grandparent, or it might be the payee or the site case manager, or it might be the physician. But how do we learn to build shared plans together for the greater whole of the community?
Thank you.
Joel Coopersmith from Georgetown. I want to ask a very narrow question about house staff. Aren't house staff important in the care of high-risk, expensive patients? And how have the rules, not only about night call, but many of the other educational rules, influenced the cost of care of these patients? And shouldn't one be thinking about how to make that part more efficient, the education of these house staff?
So we've been listening to a lot. That was a direct question. Do any of you want to try? So residents and trainees, or care plans, or
I'll just say, we're at a teaching hospital. Our service is run without house staff. We do it as an uncovered service where we provide the inpatient care.
But you're missing an important part.
And of course, there are many teaching hospitals. We're looking at expanding this model into settings where house staff would play a role. I think the key challenge with house staff isn't just their experience, but it's also the discontinuity. And so what we're trying to do is layer on top of that continuity with the attending. So the attending is the same attending in the inpatient and outpatient setting, but bring house staff into that. We do have house staff who rotate in our program, and they absolutely love it because they see a type of medicine that unfortunately many physicians have forgotten how to practice in the U.S.
I just want to say that's a very special circumstance, and the general care of patients is very much involved with house staff, and it is not very efficient as far as continuity.
Good morning. Dr. Bruce Sigsbee, American Academy of Neurology. First, a comment about the MS drugs. It's far more complex than that. There's also no evidence. There's also no evidence that, well, it's frequently brought up, no evidence that it doesn't work. And talk to my colleagues who are MS experts, and the patients who have had relapsing or remitting MS convert to chronic progressive. Do you stop all their medicines, say we can't do anything for you? It's a very difficult situation. But for the panel, two questions. One is, as you go into the dark room or maybe the dark hole, the one issue is raising adaptability to the healthcare delivery system. And for example, one of my colleagues has looked at the issue of managing patients with dementia. And as they become advanced, there are really two issues: supporting the caregiver and dealing with behavioral issues. And she has really developed a program where she's using clinical psychological social workers, relatively low expensive, doing a great job, reducing hospitalizations, doing other things, and yet that isn't paid for by traditional medicine. Another colleague dealing with patients post-stroke don't need to see the physician very often, but they need to comply with the secondary preventive measures, and been sending in educators and nurses into the home environment, so not only the patient but the family and the people there understand what's really needed to really prevent future events with also good outcomes, but again, not paid for. And then the other issue I have is really incentives, and currently the incentives in the healthcare delivery system are counterproductive to a lot of things we're talking about. And how do you really start changing those incentives? And even if you look at the Medicare alternative payment systems, what they do is they're paid on fee-for-service, and then there's an accounting at the end of the year, which doesn't really get rid of those incentives. And how do you start really looking at that seriously and really trying to incentivize the things where you start thinking about the whole patient? Start thinking about all these issues. And I think those are really some of the challenges that we face, both of those, in terms of how do we do this in a way that really meets the patient and needs of the patient or the person, and really does it in a way that's cost effective. And
so we're going to make sure you come back for part 2 and part 3 of this series, because that's where we're going. Good. Does anybody want to address the issue? So we've heard about functional limitations. We've heard about people with disabilities. People with multiple and chronic conditions and acute conditions, mental health conditions. We just heard dementia. Does that, and I think we've heard end of life, but that's a different thing. Are there any other issues we haven't touched on that you all want to?
I guess I'd like to raise an issue with My concern is that we're doing exactly to the complex multifactorial causes of illness that we did in biology, where the kidney and the liver and the lung and there's the dementia. I mean, I think one of the most important comments today was about how all healthcare is local. The reality is in most hospitals where most people get care, you're not going to build all these different programs. You're going to build one. Okay? And so I think we need to stop thinking about dissecting this problem and reintegrating it. And that's one of the things I really like about what we're doing. It is very much agnostic about the problems that it's solving. It's saying there is someone who's going to solve your problem, and we're going to inform that person with the literature. But fundamentally, no matter where you go, there they are. And they're going to come back and try to help you. And I think that's one of the most simple principles in medicine, and it goes a really long way.
Thank you. So I'm going to ask if we'll just take these last four so we can stay on time for lunch. And it's going to be 5, 6, 7, 8. Thank you.
Thanks. Amy Compton-Phillips again with KP. And I was struck in listening to all of the speakers about the foundational element that seems to make, or at least that I was hearing and interpreting your programs to be successful, and that's trust between the provider and the patient. Certainly trust is what helps us do things like stop medications that are no longer working and spending a lot of money with maybe no proven benefit, but certainly, yes, complications. So I was wondering, as we think about how to continuously evolve the care delivery and reimbursement system and what we can do to drive broad change, do you all have any kind of measurement system that allows us to understand the quality of that relationship and the trust between the provider and the patient?
We viewed that as the fundamental mechanism by which our intervention would work. So in our evaluation plan, we have a number of measures of trust, interpersonal relationship, communication, knowledge of the patient, and we're tracking all of them as they go through. And you know, the longer they're in the study, we're seeing trends that they're increasing. So we think they can be measured and are really important.
Hi, Shelley Greenfield, UC Irvine. I wanted to bring up another topic, which is to muddy the waters, which is the heavy gorilla that's not in the room, which is subspecialty care. Because we all have all these great ideas and very good models, and then we run up against our subspecialist colleagues. And disclosure, I'm a recovering subspecialist. I've been recovering for over 30 years from subspecialty medicine. What do we do to deal with our subspecialty colleagues who have a totally different mentality? At least I only just heard it face to face. What solutions are there? David Meltzer, and this is what cued me, is thought of an ingenious solution, which is to somehow hybridize them. Alan Glassoff earlier in the day said they get people together. I don't know where he found these subspecialists who will decrease the dose of anything, but he did. He found them. He said he did for one case. Telehealth, e-consults where you don't give the patients away, you just ask a single question or a couple. Are there solutions that we can think of to deal with all these young doctors who are still heading for subspecialty medicine?
Well, it's a very painful problem. So here's one painful solution. I hire psychiatrists and orthopods and cardiologists in the Department of Family Medicine. They hate it. The clinicians who come to work in a primary care setting like it a lot, but the departments where they belong don't like it at all. It's especially successful with respect to psychiatrists and psychologists who get comfortable fairly quickly in a primary care setting where the focus is on a patient, where it's also effective very quickly for sports medicine-oriented orthopods, surprisingly, and general surgeons are pretty good there. We've got, I think we'll have to kind of take the AAMC out before this is going to really work. But there's a certain kind of care that is deeply rewarding when it's personal and individualized and done in a mode that promotes partnership and teamwork. And it's not easy to sell from a distance. So sometimes I think it helps to be really noisy and disruptive. Last time I told people that, they asked me, how many times have you been fired? Which is a pretty good question for somebody working in an academic health center. But I actually think training together is as good a solution as we've got right now.
I have a fulminant case of the subspecialitis as a practicing orthopedic surgeon. I think the fact that the Academy of Orthopedic Surgeons asked me to be here tells you something. We're really interested in this. So many of the question, a big part of it was that, but there's also a big question in these Medi-Medis, access to care. Something I think we need to access to specialists, and that's one solution, but just something as we go forward with is how to address that. And from an orthopedic standpoint, functional measures are so important, and just getting to those measures. I think that's beyond our scope here, but because payment really drives behavior, maybe cutting to the end has a lot of value, and just something I see motivating my partners and my specialty. So.
You know, we are a very, I'm at the University of Chicago, we're an incredibly subspecialized institution. I have not had a problem with specialists. In fact, what I've found is over time, as they've understood what we can do to patients, they refer them to us because they want their patients to have continuity in the inpatient and outpatient setting. They want to know that the doctor who they're talking to on the other end of the phone actually understands the patient and they see the benefits. So although there are, you know, differences between specialties and economic conflicts, in clinical care, it can really align, and I think it's totally solvable.
Hi, Joanne Lynn from Altarm Institute Center for Elder Care and Advanced Illness. One of the things that we have to think about, I think, in targeting is that almost all of the conditions that yield ever entering this category are lifelong. So we really have to start counting long-term care costs and costs to the family and community as part of what is in scope, rather than just the Medicare or insured costs, and you alluded to that in your presentation. And in that sense, it seems that the delivery system also has to not only be confidence inspiring during the period of time the person's in front of them, but really has to be lifelong. Once you realize a person has serious alcoholism, it doesn't go away. Once the person's really a heroin addict, they might be a recovering heroin addict, but they're still at risk throughout their lifetime. And obviously, all of us will become frail elderly people and live for a few years with substantial disability, and you have to have a care system that can stay with you lifelong. That means that the way we train people in response to the earlier question is just wholly wrong now. I mean, you can't actually understand lifelong conditions in 1 week or 1 month rotations. You have to actually be with a person enough time to see what the struggle is like and understand the lifespan, which also then gets us back into the communities. And you can't fix this from a hospital perspective. You really do have to have communities that work and that have housing options and that have food and other essentials of life. So it seems that the care system we built around gallbladders and broken bones and appendicitis is really anachronistic, and the longitudinality is the underpinning of what we really need to move to. And I was just wondering if our targeting criteria you've been talking about and sort of the wonderful experiences you've been putting out could kind of begin to not allow people to make a living at spotty interventions. You have to be able to promise that that your system is going to be there for the rest of life and to account for the full costs.
Thank you so much, and thank you to everyone. If you join me in thanking our panelists. So they allowed me and all of us to muck things up a bit, and now we're going to try to move a little bit to clarity, and so I'm going to invite two great people up who are just going to spend the next 10 or 15 minutes before lunch trying to sum up some of what the big themes of this morning. So Mike and Peter, I'm going to turn it back to you.